Have you ever found yourself just inexplicably tired or, struggling with that persistent brain fog? Maybe feeling a chill deep down, even when everyone else seems perfectly comfortable. What if the key to all these little mysteries lies in a small, butterfly-shaped gland right here in your neck? Today, we're doing a deep dive into hypothyroidism. That's a condition where your thyroid gland just isn't producing enough hormones, and it's surprisingly widespread. Its effects can be anything from, well, a subtle whisper you barely notice to a really loud alarm that completely disrupts your life. It truly is a fascinating area to explore. So many surprising connections.
Absolutely. Our mission today is really to pull back the curtain on this condition because it's often misunderstood.
Mm.
We want to help you connect the dots between its, well, incredibly diverse symptoms, sort of demystify how doctors actually pinpoint it, look at the very causes, and finally unpack the different ways it's treated. We'll try to uncover those crucial insights that will leave you feeling, hopefully, truly well-informed.
Okay, yeah, let's unpack this medical mystery then. It's just incredible, isn't it? How a tiny gland, when it's not quite performing its best, can send these ripples through almost every single system in the body. It's not just one or two things. It's like a whole symphony of changes that can unfold, sometimes subtly, sometimes dramatically. Depends on how severe the deficiency is, right? And how fast it develops.
That's exactly right. And what's truly fascinating here is just how varied the clinical picture can be. When we look underneath at the mechanisms, we mainly see two core changes that account for most of the symptoms you mentioned. First, there's this generalized slowing of, well, pretty much all metabolic processes.
Yeah.
And second, an unusual accumulation of certain substances in the body tissues.
Okay, so let's break that down. That generalized slowing, what does that actually feel like for someone day to day?
Well, think of it like your body's internal clock is just wound down significantly. So common complaints are things like profound fatigue, a really noticeable slowing in movement, and maybe even speech. Feeling constantly cold is a big one, and often constipation. You might also see a modest amount of weight gain, though typically not severe obesity like you mentioned.
Right.
And then there are less obvious signs a doctor might pick up, like delayed relaxation in your reflexes or just a slower heart rate.
Okay. And that second thing you mentioned, the accumulation of substances, how does that show up physically? What would someone actually see or feel?
Yeah, that accumulation can lead to some pretty visible changes, things like coarse hair and skin, kind of puffy or swollen appearance in the face, especially around the eyes. Doctors call that periorbital edema.
Ah, okay.
You also notice an enlarged tongue or maybe a hoarse voice. And here's a crucial detail. These physical changes, they're often much more easily recognized in younger patients. In older individuals, unfortunately, they're frequently just, well, mistakenly put down to the normal process of aging.
That's tricky. So it really sounds like the thyroid is the body's subtle conductor, and when it's off-key, the whole orchestra kind of struggles. Let's maybe dig into some specific areas where these effects show up, because it sounds like it really is pervasive.
It really is. And beyond what we've already touched on, its effects, they touch so many systems, like skin, hair, and eyes. You might see skin that's cool to the touch, maybe pale, definitely dry, and kind of rough. That's often due to decreased blood flow.
Okay.
Sometimes there's a yellowish tinge if the body builds up too much keratin, or even hyperpigmentation, darker patches in some areas. Hair can become coarse. Hair loss is common, even thinning of the outer eyebrows, and nails might get brittle. That swelling around the eyes we mentioned, the periorbital edema, that can be a classic sign. And it's typically what we call non-pitting edema, meaning if you press on it, it doesn't leave a dent.
Interesting.
Then there's the blood system. A surprising fact here is an increased risk of bleeding. It's due to a specific acquired blood clotting disorder, von Willebrand's syndrome type 1. It impacts how your blood clots.
Wow, I wouldn't have expected that.
Yeah, surprising. Also, a decrease in red blood cell mass often leads to a mild anemia. Sometimes that's linked to other autoimmune conditions like pernicious anemia or maybe iron deficiency from heavy menstrual bleeding in women. And the cardiovascular system. Hypothyroidism leads to a reduced heart rate and also the heart's ability to contract effectively. This often causes decreased exercise capacity. You feel short of breath during exertion more easily.
Right.
Now, significant heart failure symptoms are pretty rare in people without pre-existing heart disease, but any existing heart conditions can definitely worsen. High blood pressure is also a possibility. That's due to increased peripheral vascular resistance, basically more squeeze on your blood vessels.
Okay.
And fluid accumulation around the heart, known as pericardial effusion, that can also happen, though it rarely affects heart function severely enough to cause major problems.
So yeah, it's not just about feeling tired. It can actively impact your heart's ability to work efficiently. What about breathing itself?
Well, beyond the shortness of breath that can come from the cardiovascular effects,
Hmm.
the respiratory system can also be directly impacted. People can experience weakness in their respiratory muscles, which leads to impaired breathing. And some actually develop sleep apnea, often because that enlarged tongue we mentioned can partially block the airway during sleep.
Indigestion. I imagine things slow down there quite a bit too.
Oh, absolutely. Constipation is one of the most common complaints. Gut motility, just the movement of food through your digestive tract, slows right down. Other issues can include a decreased sense of taste, and there's an increased risk of conditions like celiac disease, which is that autoimmune disorder affecting the small intestine, and also metabolic dysfunction-associated steatotic liver disease, often just called fatty liver disease.
What about impacts on reproductive health, especially thinking about women here?
Yeah, for women, the reproductive system is particularly susceptible. They might experience irregular periods or heavy periods or even absent menstrual cycles altogether. That's amenorrhea.
Yeah.
This can significantly decrease fertility, and it increases the likelihood of early abortion if pregnancy does occur.
Mm.
There's also a possibility of hyperprolactinemia, that's elevated levels of the hormone prolactin. It can potentially lead to absent periods or even galactorrhea, which is inappropriate milk production. And in men, hypothyroidism can lead to decreased libido, erectile dysfunction, and even abnormal sperm morphology, meaning the sperm shape is irregular, which impacts its function.
That is such a wide range of physical effects. What about the brain and muscles?
The nervous and musculoskeletal systems also show a really wide range of impacts. This can go from general cognitive dysfunction, difficulty concentrating, memory issues, right through to depression, and more specific problems like carpal tunnel syndrome. That's where a nerve in the wrist gets compressed, leading to pain and numbness.
Right, I've heard of that link.
Yeah. Muscle weakness, cramps, joint pains, also very common.
Hmm.
And in very severe untreated cases, it can even lead to profound confusion and altered consciousness. That's a life-threatening condition called myxedema coma. We also see an increased prevalence of hyperuricemia, high uric acid levels, and gout, that type of arthritis caused by uric acid crystals. That's often due to decreased kidney function related to the hypothyroidism.
And finally, are there specific metabolic abnormalities we should be aware of?
Yes, definitely. Hypothyroidism can significantly impact cholesterol metabolism. It often leads to elevated total cholesterol and especially the bad LDL cholesterol that can increase cardiovascular risk.
Okay.
Other issues include hyponatremia, which is low sodium levels in your blood, and elevated muscle enzyme levels, particularly creatine kinase. That's an enzyme usually found inside muscle cells. High levels can indicate muscle damage or stress. And what's also crucial, really crucial, is that the body clears many common drugs more slowly when you're hypothyroid. This includes certain anti-seizure meds, anticoagulants, hypnotics, opioid medications. So drug toxicity can occur if doses aren't reduced. It really highlights the need for careful medication management, which, brings us to an important question. If the symptoms are so varied and often quite subtle, particularly in older adults who might just seem slowed down, how do doctors actually diagnose this complex condition?
Yeah, given how nonspecific so many of those symptoms sound, it seems like laboratory tests must be absolutely crucial for a definitive diagnosis. It's not something you can just guess based on how you feel, right?
Exactly, you've hit it. The diagnosis relies heavily on specific blood tests. Primarily, we're measuring thyroid-stimulating hormone, or TSH, and free thyroxine, which is T4. Those two measurements really help us differentiate between the different forms.
So what's the clearest cut case? The most obvious one?
That would be what we call overt hypothyroidism. This is where the TSH levels are clearly high, that shows the pituitary gland is working overtime trying to stimulate a sluggish thyroid. And the free T4 levels are low, confirming the thyroid just isn't producing enough hormone. Pretty straightforward usually.
Okay, and then there's this category that seems to spark a lot of questions and can be, well, quite tricky. Subclinical hypothyroidism. What distinguishes that one?
Yeah, this is where it gets really interesting and honestly can be a bit of gray area sometimes. With subclinical hypothyroidism, the TSH is elevated, so the pituitary is still pushing the thyroid, but the free T4 level is still within the normal range.
Oh, yep.
Many patients in this category are genuinely asymptomatic. They feel perfectly fine, while others might have some minimal, maybe vague symptoms, but they aren't always consistently linked to the condition itself. Then there's also central hypothyroidism, much less common. This happens when the problem isn't actually with the thyroid itself. It's with the hypothalamus or the pituitary gland up in the brain, which control the TSH. In these cases, free T4 is low, but surprisingly, TSH might be low or normal or even slightly high, but it's not appropriately elevated like it should be when T4 is low.
Right, the signal isn't matching the situation.
Yeah.
So beyond someone walking in with those classic symptoms, who else should maybe be getting their thyroid checked? Are there specific risk factors or other conditions that might warrant testing?
That's a great question, because while anyone with suggestive symptoms should definitely be tested, there are specific groups where we often recommend screening. This includes people with certain risk factors or maybe other unexplained lab abnormalities. Things like substantial hyperlipidemia that's very high cholesterol, or hyponatremia low sodium levels, high serum muscle enzyme concentrations like that creatine kinase we mentioned, or a macrocytic anemia where red blood cells are larger than normal. Also, definitely anyone with a personal or family history of autoimmune disease, or prior thyroid injury from treatments like radioiodine therapy or external neck irradiation.
Okay.
And significantly, patients taking certain medications, especially newer cancer therapies like checkpoint inhibitors or tyrosine kinase inhibitors, as these can directly affect thyroid function, sometimes quite rapidly.
Right. Yeah, I've heard some talk about normal TSH ranges potentially changing with age. It sounds really counterintuitive to how most people think about lab results. What's that all about?
That is such a crucial point and often a surprising detail. It really highlights the nuance in diagnosis. While a typical upper limit of normal for TSH in most labs is around, say, 4.5 NUL,
Yeah.
some experts argue pretty convincingly that this upper limit naturally shifts higher with age, especially for individuals over 70. For them, the normal upper limit could actually be as high as 6 to 8 MUL.
Wow, that's quite a difference.
It is, and we also see this in individuals with class 3 obesity where that upper limit might go up to 7.5 MUL. So what this means is that what's considered elevated TSH can genuinely depend on the patient's age and other health factors. It makes interpreting that TSH number a truly nuanced art, not just looking at a simple number on a page.
Okay, that's really important context. So we've covered what hypothyroidism looks like, how doctors diagnose it with these blood tests. Now let's shift our focus to the why. What actually causes this hormone deficiency in the first place?
Right, so the vast majority of cases fall into what we call primary hypothyroidism. That just means the issue is directly with the thyroid gland itself, and by far the most common cause of hypothyroidism in iodine-sufficient regions of the world. So places like North America, where people generally get enough iodine, is Hashimoto's thyroiditis.
Hashimoto's. Okay, that's a name many people have probably heard. What exactly is it?
It's an autoimmune condition, which means your body's own immune system, which is supposed to be protecting you, well, it mistakenly attacks and gradually destroys your own thyroid tissue.
So your body is fighting itself.
Exactly. It's your body fighting itself. More than 90% of patients with Hashimoto's have high levels of specific antibodies in their blood, called thyroid peroxidase antibodies. They're a key indicator. It's significantly more common in women, maybe 5 to 8 times more prevalent. And how often it occurs, the incidence increases with age. A family history of thyroid disorders is also pretty common, and it can be associated with other autoimmune conditions like celiac disease or type 1 diabetes.
So your own body attacking your thyroid? That's a pretty surprising fact for many, I think. What else can cause this deficiency? Is it always an internal issue like that?
Not at all. Actually, many cases are what we call iatrogenic. That means they're a direct result of medical treatment. This includes things like surgical removal of the thyroid, called a thyroidectomy, or radioiodine therapy, which is often used to treat an overactive thyroid, hyperthyroidism, or thyroid cancer. Even external neck irradiation, used for cancers like Hodgkin lymphoma or head and neck cancer, that can cause hypothyroidism to develop, sometimes weeks, months, or even years later. It's often an expected side effect of a necessary, successful treatment for another serious condition.
Okay. What about iodine? We hear a lot about its importance for thyroid health. Can too much or too little actually cause problems?
Iodine imbalance is indeed a critical factor, and the surprising part, both too little and too much iodine can cause problems. Globally, iodine deficiency is actually the most common cause of hypothyroidism and goiter that's an enlarged thyroid gland. It affects roughly 2 billion people worldwide.
Wow.
However, it's quite rare in places like North America because we have widespread iodized salt in our diet. But on the flip side, iodine excess can also be a culprit. While healthy thyroids can often adapt and escape the effect of excess iodine, those with underlying issues like chronic autoimmune thyroiditis or maybe previous thyroid treatments, they often can't adapt. and they can become hypothyroid from too much iodine.
Where would someone get excess iodine from?
Well, it can come from some unexpected sources, certain health tonics, some cough medicines, kelp tablets, also specific medications like amiodarone, that's a heart medication that's very high in iodine, or even radiographic contrast agents used in medical imaging like CT scans.
Huh. So it's not just natural causes or medical procedures then. Are there specific medications besides amiodarone that can actually impair thyroid function?
Absolutely. There are quite a few medications used for conditions completely unrelated to the thyroid that can unfortunately impair its function. Common culprits include lithium, which is often used for mood disorders, amiodarone, as we just mentioned, because of its high iodine content, things like interferon alpha and interleukin-2, which are used in some cancer treatments and for certain viral infections. And those newer cancer therapies we talked about earlier, the tyrosine kinase inhibitors and checkpoint inhibitors.
Right.
It's incredibly important for healthcare providers and patients, too, to be aware of these potential drug interactions so thyroid function can be monitored properly.
And sometimes this hypothyroidism isn't even permanent, is it? It can be a temporary state.
That's a very important point and often a hopeful one for patients. Sometimes, yes, hypothyroidism is indeed temporary. This can happen during the course of certain types of thyroid inflammation, known as thyroiditis. Things like painless thyroiditis or subacute thyroiditis, where the thyroid gets inflamed but then usually recovers. Also, postpartum thyroiditis, which can happen after childbirth, is often a temporary form.
Okay.
Identifying this distinction is really crucial because it can help avoid unnecessary lifelong treatment for something that might just resolve on its own. And if we connect this back to the bigger picture, knowing the specific cause really helps doctors figure out if the hypothyroidism is likely permanent or temporary. And crucially, it guides the most appropriate and effective treatment strategy for you.
Right. So once someone gets that diagnosis and you know it's likely permanent, what's the typical treatment approach? What does that involve?
For most permanent cases of hypothyroidism, the treatment is actually quite standard and usually very effective. It involves daily oral administration of synthetic thyroxine, also known as levothyroxine.
Levothyroxine, okay.
This medication is essentially just a replacement for the T4 hormone that your thyroid isn't producing enough of. Now, T4 is technically a prohormone. That means your body then converts it into T3, which is the active form of the thyroid hormone that your cells actually use. So the treatment is really all about safely restoring that natural hormonal balance your body needs.
Does the specific dose of levothyroxine matter significantly? And how is that figured out for each person?
Oh, absolutely. The dose matters profoundly. It's not one size fits all. While the average full replacement dose for adults is somewhere around 1.6 micrograms per kilogram of body weight per day,
Yeah.
the actual range of required doses is really quite wide. It's highly individualized. For instance, for young, otherwise healthy patients, we might start with the full anticipated dose right away. However, for older patients, or maybe those with underlying coronary heart disease, we have to be much more cautious. We start with a much lower dose, perhaps 25 to 50 micrograms daily.
Why the caution there?
It's because thyroid hormone increases the heart's oxygen demand. So starting too high carries a small but real risk of inducing cardiac arrhythmias, irregular heartbeats, or angina, which is chest pain, in people who are susceptible. So it's a careful titration upwards.
Got it. How long does it typically take for someone to start feeling better once they begin treatment? And how do doctors monitor if the dose is actually correct?
Well, symptomatic improvement, actually feeling better, can begin relatively quickly, often within about 2 weeks.
Oh, that's good to know.
However, it takes about 6 weeks for the TSH levels in your blood to fully stabilize after you initiate treatment or adjust a dose. So monitoring primarily involves regular TSH measurements. Typically, we check every 6 weeks initially until those levels are consistently in the target range we're aiming for.
And what is that target TSH range? Is it the same for everyone?
Another nuanced area. For younger adults, the goal TSH is often to keep it within the normal laboratory reference range, which is usually something like 0.5 to 4.5 MUL. Some experts even aim for the lower half of that range.
Okay.
But for older adults, say those over 60 or 70, we need to remember that TSH naturally increases a bit with age. So a slightly higher target might be more appropriate for them. We might aim for a TSH between 3 and 6 MUL, or maybe even slightly higher, up to 7.5 MUL for octogenarians, people in their 80s. This adjustment is really important to avoid the potential risks of overtreatment, which can be more pronounced in older populations.
Right, that makes sense. Now, that brings up a really important question. What about those cases where someone is on P4 therapy, their TSH levels look normal on the lab report, but they still report persistent symptoms like fatigue or brain fog? That sounds incredibly frustrating for patients.
It absolutely is. And this is indeed a challenging area, both for patients and for clinicians. It's also an important question for ongoing research. Look, the vast majority of patients do feel well on T4 monotherapy, meaning just taking levothyroxine alone. But, as you said, there is a subset who might report persistent fatigue or other, non-specific symptoms, even when their TSH is technically normal.
So, what can be done?
Well, current research from large randomized trials generally indicates that adding T3, the active hormone, to the T4 doesn't offer significant additional benefits for most patients. However, for a very select subset of patients, maybe those who have absolutely no residual thyroid function left at all, or perhaps those with specific genetic variations that affect how their body converts T4 into T3, a trial of combination T4-T3 therapy might be considered. But it's complex, because the commercially available T3 formulations can lead to these sort of non-physiological peaks and troughs in blood levels, making it quite tricky to manage safely and effectively.
So, it's definitely not as simple as just thinking more hormone is better. Are there actual risks, then, to being on this treatment, even if it's needed?
Absolutely. Both over-replacement, taking too much thyroid hormone, and under-replacement, taking too little, carry distinct risks, which really highlights why that careful, individualized monitoring is so critical.
Okay, what are the risks of too much?
Over-replacement, where the TSH gets suppressed too much, can lead to a state that mimics subclinical hyperthyroidism, an overactive thyroid state. The main risk here, especially in older patients, is atrial fibrillation. That's an irregular and often rapid heartbeat that can significantly increase stroke risk. It actually occurs about 3 times more often in older patients whose TSH is pushed below 0.1 MUL.
Wow.
Over-replacement also poses a risk of accelerated bone loss, particularly in postmenopausal women, which can increase their fracture risk down the line.
And not enough hormone. Under replacement.
Right, under replacement, where the TSH remains persistently high because the treatment dose isn't adequate, that's also not benign. It can increase cardiovascular morbidity and mortality as well. So it really is a delicate balancing act to achieve precisely the right dose for each individual. Not too much, not too little.
Definitely sounds like it. Now let's circle back to that subclinical hypothyroidism we touched on earlier. This is a part of the deep dive that often sparks, well, a lot of questions. And it can be a source of significant debate in the medical community, right? What exactly defines it again, and why is it so often a topic of discussion?
Right, so it's defined purely as a biochemical diagnosis. Remember, you have an elevated TSH, but your free T4 level is still normal.
Elevated TSH, normal T4. Got it.
And as we discussed, many patients are genuinely asymptomatic. They feel no different, but some might report those vague complaints, fatigue, constipation, although these aren't consistently linked directly to the condition itself in studies. It's quite common, actually. Affects anywhere from maybe 4 to 15% of the general population in studies. And its prevalence rises significantly with age, and it's more common in women. Importantly, a substantial proportion of patients with subclinical hypothyroidism eventually do progress to overt hypothyroidism, especially if their TSH is consistently above 10 MUL, or if they have those autoimmune thyroid peroxidase antibodies we mentioned earlier.
Okay, so given this biochemical diagnosis, what are the potential consequences if subclinical hypothyroidism is just left untreated? This sounds like the real core of the debate.
This is indeed where the debate really heats up. And the evidence is still evolving, honestly. If we look at cardiovascular disease, some studies do suggest an increased risk of coronary heart disease and heart failure, particularly when the TSH concentration is consistently above 10 MUL. It can also be associated with unfavorable lipid profiles, like higher LDL cholesterol, though the actual clinical importance of that link is still debated. Interestingly, some data suggest that T4 replacement might actually offer cardiovascular benefits in younger patients with subclinical hypothyroidism, but perhaps less so in older individuals.
And for mortality, the ultimate health outcome, are the findings clear there?
Yeah, for mortality, the studies show conflicting results, which just further fuels the debate. Some studies do indicate an increased risk of cardiovascular and/or all-cause mortality, especially with those higher TSH concentrations, again, often above 10. However, other studies, particularly those focusing on community-dwelling older adults, especially those 80 years and above, have found no increased risk. And some have even reported a lower mortality rate associated with mild TSH elevations in this very elderly population.
Lower. That's surprising.
It is. It really highlights the complexity and, again, the need for personalized approaches based on age and overall health.
What about its impact on reproductive health, beyond what we discussed for the overt form?
Well, there's a clearer evidence of an increased risk of pregnancy loss in women with subclinical hypothyroidism. And interestingly, even in women who have normal thyroid function but test positive for those autoimmune thyroid peroxidase antibodies. It can also be associated with increased sperm DNA fragmentation in men, which can affect male fertility. Beyond reproduction, it's also been correlated with that metabolic dysfunction-associated steatotic liver disease, MASLD. And in some studies, though, not all with vague neuropsychiatric symptoms like memory defects, particularly in middle-aged adults.
Okay, this sounds incredibly complex. A lot of it depends. So, does everyone with subclinical hypothyroidism actually need treatment? How do doctors navigate this uncertainty?
That truly is the million-dollar question, isn't it? And there's no universal yes answer for treatment. Most experts generally do recommend treatment for TSH levels that are consistently 10 MUL or higher. That's primarily due to that increased risk of progression to overt hypothyroidism and those potential cardiovascular concerns we discussed.
Right, the 10 threshold seems key.
Yes.
Yeah.
Also, for women who are actively trying to conceive and are experiencing ovulatory dysfunction or infertility, treatment is often suggested if their TSH is above their specific target range for fertility, which is usually lower.
So, when is treatment more controversial or less clear-cut? Where's the gray area?
The gray area is really for those TSH values between roughly 4.5 and 10 MUL, especially in patients who are completely asymptomatic or in older adults, say over 65 or 70 years old. In those cases, the benefit of treatment becomes much less clear. The decision then really needs to be highly individualized. It involves weighing your specific symptoms, if any, the presence or absence of those autoimmune antibodies, and definitely your age.
What are the arguments against treating?
Well, arguments against treating these milder cases often include the cost of lifelong medication, the daily commitment required from the patient, and the very real potential risk of overtreatment, which, as we discussed, carries its own set of dangers, particularly for the heart and bones in older individuals. It really should be a true shared decision-making process between the patient and their doctor.
So what's the key takeaway then for someone listening? Maybe someone wondering about their own thyroid health or perhaps a recent lab result that fell into that gray zone.
I think the key takeaway is the importance of regular follow-up if you are diagnosed with subclinical hypothyroidism, and a decision is made not to treat it immediately. Your thyroid function should be monitored, typically yearly after an initial check at maybe 6 months. This is to catch any progression towards overt disease, or maybe just to reevaluate the decision to treat based on any new symptoms that develop, or even just evolving research. It's really about ongoing vigilance and partnership with your provider.
Wow. That was truly a deep dive into the thyroid gland, wasn't it? From those really subtle signs that can mimic just everyday woes to the intricate dance of hormones and immune responses. It's just abundantly clear that this tiny gland plays a monumental role in our overall well-being. It really is like the quiet orchestrator of so many bodily functions.
Indeed it is. And understanding its varied manifestations and nuances of diagnosis and all the complexities of treatment is just key to managing health effectively. This whole journey through hypothyroidism really underscores how interconnected our body systems truly are, and how even seemingly small imbalances in one area can have these widespread, sometimes unexpected effects.
So what does this all mean for you listening right now? Well, perhaps it's a gentle reminder to pay closer attention to those persistent, maybe vague symptoms you might have been dismissing. Just putting down to getting older or being tired. Or perhaps it empowers you to have a deeper, more informed conversation with your healthcare provider about your own thyroid health, armed now with a better understanding of its incredible influence. And just to wrap up, here's a final provocative thought for you to maybe mull over. Given that the average lifespan is increasing, and we're learning that these normal ranges for TSH seem to shift with age, how might our understanding and management of common conditions like hypothyroidism continue to evolve in the coming decades? Will a slightly higher TSH in an 80-year-old eventually become universally accepted as just a benign sign of healthy aging? Or will we uncover new, maybe age-specific ways to optimize thyroid function in our ongoing pursuit of longevity and vitality? Something to think about. Thank you so much for joining us on this deep dive. Until next time, stay curious and keep learning.